11:26 হলো।
স্যার ভেরি গুড মর্নিং।
চেয়ারপারসন কে আছে? ওই তো পার্থ সরকার। Colleagues, now we are going to resume our master class for the day. I request Dr. Harishankar Pathak, who is ex-chairman, immediate past chairman of API West Bengal branch. Also, he is the present governing member of API. Dr. Harishankar Pathak, you please introduce Partho Sarkar and if the subject if you think.
Good morning, everybody. At the outset, I thank Dr. Amal Kumar Banerjee, Chairman of ICP West Bengal Forum, for giving me this opportunity to introduce today's chairperson, Professor Partho Sarkar. Now, it is my pleasure to introduce Professor Partho Sarkar, who had a long association with me. He had been a professor at different medical colleges, and finally he came over to National Medical College. From here, he retired just 2 days back. He had an excellent record as a good teacher, good human behavior, having good human behavior, and apart from that, he is also chairman of Indian Rheumatology Society of India. He had been he had the credit of having so many posts in Indian Rheumatology Society as well as API West Bengal branch. So today's topic, I hand over the mic to the podium to Dr. Sarkar. Before that, today's topic is very interesting, and it is very helpful for postgraduate students who will be joining and listening to the program. Over to Professor Sarkar, please.
Good morning, everybody, whoever present. And at the outset, my sincerest thanks to Chairman Dr. Amal Kumar Banerjee, ICP West Bengal Chairman, and also API West Bengal Chairman Dr. Anando Bagchi, and the course coordinators Dr. Apurva Mukherjee, Dr. M.K. Rai, Dr. R.N. Sarkar, and Dr. Satyabroto Ganguly, to entrust me with the responsibility to chair this session of a very important topic. The topic is extremely important in that respect. It is a silent disease, and the challenge to the physician is to diagnose it before the first fracture. That is the most important task of a physician. And it is a burden for all the countries, Western and Eastern. Mainly in our country, almost 1 out of 8 males and 1 out of 3 females suffer from this osteoporosis. More than 20% females over the age of 50 suffer from this. So it needs great attention. And so to talk on that, we have none other than Dr. Parthajit, who is an erudite and prolific speaker and had a lot of works on this subject, both nationally and internationally. So without wasting any further time, I will request Parthajit to start his deliberation on the topic. Thank you.
Okay, thank you, sir. So it's a proud privilege to be a part of this meeting. I'm just sharing my screen now, just a sec. So is my slides visible?
Yes, visible.
Okay. So good morning, everyone. So I've been asked to do a very important presentation, which is quite relevant to the clinical practice. So it's a clinical approach to osteoporosis, a physician's perspective. This is a huge topic to be covered in a short time. So I'll try to make it very simple as practical as possible. So this is the overview of my talk. So how do we diagnose osteoporosis? I've got 5 interesting, very real-life cases. We'll discuss the controversies in the case-based discussions in the management of osteoporosis. So like, what are the duration of therapy? How long do we have to continue treatment? Do we need to consider drug holidays, and how do we do that? And especially for high-risk patients, what are the role of combination therapies or sequential therapies? Obviously, we have got few researchers on board, and we have got few new molecules. I'll discuss very briefly a few of them, like romosozumab or abaloparatide. Now, what is the impact of osteoporosis on health? So if you look at the US data, like Enhance 3 data, so more than 9.9 million Americans have osteoporosis, and additional nearly 45 million have low density, the osteopenia. But this is an old figure, 2014. Again, if you look at the UK figures, this is relatively almost remained same. So osteoporosis affects more than 3 million population, 1 in 2 women and 1 in 5 men more than 50 years will have osteoporosis-related fractures in their lifetime. And it is estimated that nearly 300 fragility factors occur in UK in a year, and out of which 70,000 are hip fractures. And amongst these patients, 14,000 death rate. So the mortality is very high. So this osteoporosis has a significant burden, clinical and financial, in the social life. Now, we all know about UK, US figures. So what's happening in India? In the census trial, we know that the longevity, the life expectancy has increased significantly since 1951. It really doubled. So all the chronic diseases like diabetes, hypertension, osteoporosis, everything is on the rise. And it's estimated that nearly 50% of Indian women have osteoporosis, and probably many more have undiagnosed osteopenia. And the number of osteoporosis fragility hip fracture was expected to be around 500,000 in 2020, and expected to be rising quite quickly to be nearly about 1 million in 2050. These figures are quite staggering. So our main motto is to identify, diagnose, and treat osteoporosis at the earliest to an optimum level, so that minimize the first fracture, the primary prevention, which Partha sir has just mentioned. Now, in that case, so what is osteoporosis? So we all know the densitometric definition of osteoporosis, which is given by WHO in 1994. But the NIH Consensus Conference, they have mentioned that osteoporosis is a skeletal disorder, which is characterized by compromised bone strength, predisposing a person to an increased risk of fracture. So what does it mean? So when we quantify bone strength, it has two components. One is bone quality, another is bone density. What we do in our diagnostic strategies, we only diagnose the bone density through DEXA scan. But we miss quite a lot of things through the bone qualities. We don't really assess that. So what are the components of bone quality? Just a second. Yeah. So you can see bone density constitute around 60% of bone strength, whereas bone quality is around 40%, which is nearly quite a massive amount. And what does it suggest? It considers the matrix proteins like bone turnover rate, what is the damage accumulation, a mineral quantity, like what are the calcium content, various contents of the factors, and degree of mineralization. Macro architecture is again important, which is the larger bone, smaller bone size, and again the micro architecture, which I'm coming in a minute. So what we do when we diagnose osteoporosis is mainly looking at the bone density, and the bone quality is significantly, we miss out most of the times. So this is the trabecular bone. It's a spine. It has seen, you can see quite a bit of horizontal and vertical struts, which gives the strength of the bone in a trabecular bone, which is vertebrae. Over the period of time, if osteoporosis is not treated, or someone has osteoporosis, you can see a lot of thinning there, thinning of the trabecula itself. There is loss of horizontal and vertical struts. So bone becomes quite spongy, and they can't bear the weight. And finally, if it's not sorted, they become extremely porous, and they tend to have fracture. So even with minor twists and turns, a osteoporotic woman in 60s and 70s can develop fracture, and that can go without any symptoms. So probably we need to be aware and detect fracture and start optimum treatment. So overall, what happens in osteoporosis? There is decrease in bone mass. There is decrease in trabecular thickness. The trabecular number and the horizontal and vertical struts are lost. So the connectivity. So when we see a house being built, the scaffolding, all the horizontal and vertical, they're all equally significant. If any of the struts or the connections are lost, that results in decreased bone strength or the strength of the scaffolding. Now, when we talk about or define osteoporosis, usually the postmenopausal women or the primary osteoporosis we mean, and most of the studies have included women with postmenopausal osteoporosis. Not many studies have included secondary osteoporosis, but there's more than hundreds of causes which can cause or we can aggravate osteoporosis. It could be endocrine causes like diabetes, thyroid disorders. It could be nutritional gastro causes like malabsorption syndromes, multiple drugs which we use very often for a prolonged period of time, like anti-epileptics, PPIs, steroids, SGLT2 inhibitors, several thyroid drugs can, for a long time, can cause osteoporosis as well. And various chronic infections like HIV, tuberculosis, and even the autoimmune disease, rheumatic, SLE, etc. So let's come to the first case. So he's a 69-year-old woman, known rheumatoid, on methotrexate and injections. Had a DEXA scan 5 years ago, which means little bone loss, so patient can't recollect. Non-smoker, non-drinker, takes calcium, vitamin D daily, had a family history of hip fracture. So no accentuation of spinal scoliosis on clinical examination. So this patient, does she have osteoporosis? How do you diagnose that? The tools what we have in our kind of pocket is the DEXA scan. So what is a DEXA scanner? Is mainly two machines are very commonly used. One is GE Healthcare and one is the Hologic. So the patient is asked to lie on the bed and the scanner moves over the patient, and they scan usually the spine from L1 to L4 and the hips, especially the either total hip or the hip neck, the femoral neck. But having said that, on few occasions, if patients have laminectomy or spinal surgery with metal screws or both hip replacement, then you go for the forearm DEXA. And sometimes even you can't do forearm DEXA because they have a lot of fractures. So in that case, at the last resort, you can do a quantitative US study for the bone density, but it's not much validated. So mainly as of now, this is probably the best tool what we have. And that includes mainly the spine and hip. This is the kind of standard reporting tools which we use. That includes demographics, T-scores and Z-scores, which defines the osteoporosis or kind of negates osteoporosis. As a graph which tells you if it's on the same machine, that there's a graph that will tell you whether density is increasing or decreasing. And obviously the hip or spine is imaged, but there are a lot of technicalities which has to be taken into consideration to have a proper imaging and proper report. Now, how do you define osteoporosis, which is defined by WHO in 1994? So someone, if having bone density less than -1 T-scores, is called osteopenia. So that's between -1 to -2.5 is osteopenic range. If someone T-score is less than -2.5, defined as osteoporosis. And if someone has either severe decrease in T-score less than 3.5 or T-scores around 2.5 with a fracture, then you define as severe osteoporosis. Now, we all talk about T-scores, but what are the importance of Z-scores? So you can see that with the Z-score, you compare the bone density with a person of the similar age groups. That means the secondary osteoporosis comes in the picture. If someone has a reasonably low T-score and the Z-score is quite significantly low, which is less than 2, then you have to think of secondary osteoporosis. But Z-score is commonly used in pediatric population and young adults. Just be mindful that osteoporosis, WHO 1994 criteria includes patients more than 50 years. So if you define someone to have osteoporosis or osteopenia, it has to be the Z-score which has to be calculated, especially in child or peds patients. When you use Z-score to define the low bone density, it's better to use the term low bone density appropriate for age rather than using osteoporosis, because the child, I think they really gain bone density fairly quickly. Now, this chart is very, very important. If you go from left to right, the bone density is decreasing. That means if you go on the right, the bone density is significantly low because the score is -3.5. And on the left side is at more than 1. Interestingly, the gray bar is the fracture rate. So it's quite obvious that as the bone density is reducing, the fracture rate is increasing. That's absolutely fine. But the concern is the black bar. You see a significant number of patients, women, nearly more than 50%, they are having fractures in the osteopenic range. So when the T-score is even more than, not less than 2.5. So many patients are getting fractures at this year. That means just defining osteoporosis through a DEXA scan, we are certainly missing certain points, which is the bone quality, like TBS scores and things, or what comes in the picture. So that's the next question. So how do you define or kind of diagnose bone quality? So one option, you can include a TBS score, which is a software you can use in the same DEXA machine. It's quite a bit expensive software, but that will give you a 3D directions or the trabecular structure, the microarchitecture of the bone. Another way of defining is a CT or MRI. So that gives it 3D dimensions, a number of struts, vertical, horizontal struts, and you can compare from the previous CT scan as well. But the mineral content, like the osteoclast activity, osteoblast activity, how are they? What are the numbers of osteoblasts? These are very tricky and important when you define a CKD MBD, like chronic renal failure patients, whether it's a renal osteodystrophy or not. So in those patients, DEXA doesn't have a significant or very highly sensitive or specific roles. So bone biopsy, although is rarely done, they have a role, especially in those kind of patients. So let's come to our case. So our patient is a 69-year-old woman with rheumatoid arthritis on DMARDs, had a family history of fracture. Now the DEXA is showing osteopenia. So T-score -2, femoral leg -1.1. So does she need treatment? That's the important question. So how do you define or assess this patient or risk stratify this patient to have a high risk of fracture? So if you look at the American Endocrine Society guidelines, so number one, if someone has osteoporotic T-scores, like the densitometric scores like T less than 2.5 in femoral neck, spine, total hip, or distal radius, you can define them as osteoporosis, that's fine. But this patient doesn't fit in this picture. So next is if someone having osteopenic range, that means T-score -1 to -2.5 and having a fragilated fracture, those patients need treatment. Again, our patient is not in there. So what will happen next? So if someone having osteopenic range, so you have to risk stratify, and that's the FRAX assessment. You can include either, bone densitometric measures like T-scores, bone density, or you can use TBS FRAX scores in it as well. And that gives you 10-year fracture risk figures and the 10 years hip fracture figures. So if the risk fracture of major osteoporotic fracture is more than 20%, and the hip fracture is more than 3%, that means a patient is a high risk of fracture, and you have to start treatment. So what is a FRAX score? So it's a statistically robust fracture risk prediction tool developed by WHO again. That predicts a risk fracture in major osteoporosis fracture and hips. This is country specific, and you can use this is a very good tool to risk stratify someone to having osteoporosis related fractures, and use it with discretion when probably you don't have densitometric or this kind of patients where osteopenia or just to qualify for high risk. So we have a validated Indian FRAX. You can see there are few checkpoints you have to fill in. So the patient details like previous fracture, parental fracture, at least 12 details you have to fill in. You can select either BMD or T scores, but now the newer version have TBS scores as well. So once you fit in all these data, that will give you a fracture risk assessment. So if the major osteoporosis risk factor is more than 20%, or the risk of hip fracture is more than 3%, you can stratify someone to have a high risk of fracture, and these patients need treatment irrespective of the bone score. So suppose in our patient, when we did the, I'm coming in a minute. So, but this FRAX assessment has a lot of limitations. They haven't included many things. Then came the FRAX Plus. So they have included the limitation, or they have tried to fill in the gap, or the FRAX, the main FRAX, like the recency of fracture. So when was this fracture? Is it a very recent fracture or very old fracture had 10 years ago? Or what is the dose of steroids used? whether include diabetes as a risk factor, any concurrent data on lumbar spine, because usually FRAX assessment use hip data, like total hip BMD. But FRAX Plus also includes hip and lumbar spine. Again, they have included TBA scores, history of falls. So if you have multiple falls in the past, so your risk is much higher. So that's also included here. And they also included the hip axis length. If it's shorter, the risk is high. Now let's come to our case. So when we did the FRAX assessment, so 10-year probability around 20% and hip fracture was 3.5%. So that means irrespective of having a low bone density, because of the high risk factors, known rheumatoid, long-term medications, previous history of family history of fracture, so this patient's risk of having osteoporosis fracture is quite high. So that means she needs treatment. So first question is, does she need treatment? So question is yes. So when you decide someone to having a treatment, so what other options you have to think? So next is, what are the treatment options we have in hand? What is the duration of therapy? Because this patient is 69, probably she will live another 20 years, so maybe in 90s. So will you continue treatment for next 20 years, or do you want to go for a drug holiday? So those are important decisions. And when do you need to stop treatment? So is there any ways or kind of means or mileage to having an assessment of ways to stop medication? Now, there are various FDA-approved drugs like bisphosphonates, which we all know, which we all use in your daily practice, like alendronic acid, ibandronic, risedronic, zoledronic acid. Calcitonin is very poor role in bone density, but is used mostly by the orthopedic surgeons. Again, SERMs have a very limited loan. Teriparatide, denosumab, they're all FDA approved now. So, and another way of looking at things, so what are the treatment options? So lifestyle play a very, very significant role, like smoking cessation, alcohol, you have to reduce intake of alcohol, regular exercise, fall prevention, regular calcium, vitamin D supplementation. So when someone having a very high risk of fractures, always supplement vitamin D to an optimum level and then start medications. So various treatment options are there, like daily options, weekly options, monthly options, quarterly, 6-monthly, 12-monthly. So you discuss the options with your patients. So if patients are agreeable and they want to try this form of medications, and they can pick and choose. Obviously, you have to discuss the risk of the medicines with the patients as well. So another way of looking things, so there are two groups of drugs. One is anabolic. That means they increase the bone density. They kind of stimulate osteoblasts to cause more bone formation. The other is anti-resorptives. That means they reduce the osteoclastic activity or bone resorption. So the anti-resorptives are bisphosphonates, denosumab, calcitonin, SERMs, which we commonly know. For anabolics, there's two forms. One is remodeling stimulators. That means they increase formation and resorption. So that means they kind of stimulate osteoblasts, and to some extent, they include the osteoclast as well. So if you use teriparatide for a long time, maybe more than 2 years, the bone density goes in a standstill, and sometimes the hip density goes down as well. That also holds true for the newer drugs. But the next is the modeling stimulator. So they increase osteoblast activity and reduce osteoclast. That means there's a modeling stimulator, which is the new drug in town, romosozumab. And one more drug, odonakative, has shown significant improvement, but that's been withdrawn from the market because the risk of CDA, the stroke was very high. So I think withdrawn a few years ago. There are several guidelines. You can always refer to one of them, but there's quite a bit of difference in between the guidelines. So probably NOG guidelines, IF guidelines are better, or ACR guidelines is also there for steroid-induced osteoporosis. Just have a look through it. So what are the lifestyle advices? So smoking cessation, alcohol moderation. It's always said that it's not to take alcohol. But if patients are desperate, they can have a low volume of alcohol, as I mentioned. Exercise is very, very important. So regular weight-bearing exercise, 30 to 40 minutes, almost 5 to 6 times a week. And back and posture exercises, at least 3 to 4 days a week. Fall prevention strategies equally important for elderly patients, like whether they have a carpet on floor, whether this the bathroom or the the movement area is well lighted. Any rails in the kind of stairs or any rails in the toilets to get up, because those are the areas they tend to fall. So this is a very, very important part, and the orthotics can take care of these once they're properly assessed. So there's quite a bit of kind of debate about calcium, vitamin D supplementation, and various recommendations and various figures. The Women Health Initiative study has showed that if somebody is supplemented regularly with 1,000 milligram calcium and 400 vitamin D, so there is a significant 1% increase in BND, which is not too bad really. That means the T scores goes up by minus 2 to significantly really. But overall, what are the values? The things which you need to keep in mind: if someone is more than 70, so calcium intake is 1200 per day, and if someone is more than 70, is 800 vitamin D, and if it's less than 70, so 1000 calcium and around 600 vitamin D. So what are the efficacy of treatment at various states? See, you have a list of medication, but see, not all the drugs have an effect on all the skeletal sites, like vertebral, non-vertebral, and hip. Even teriparatide, the newer drugs, they have effect on vertebral and non-vertebral, but not much effect on the hip. So like alendronic acid, denosumab, risedronic acid, and zolendronic acid, these are the 4 groups of drugs which have efficacy on all the skeletal sites. Even you can say abaloparatide, teriparatide, they have poor effect on the hips, but they have quite a robust effect on the spine. This is again a very interesting study they have found. So the x-axis is the kind of the DEXA result, like the bone density, and the y-axis is the TBS score. So this is mainly help you to decide which drugs to choose for which patient, because you see, if you use BP is the bisphosphonate. If you use bisphosphonate for a patient, so the annual increase in BMD is around 5%, but the TBS scores is not much. So although the bone density increases probably in the cortical bones, but the trabecular bones is not affected much in a year. So the bone strength is not increased. Whereas in denosumab, the bone density is increased around 8%, and the TB is around 3%. So which is definitely better than bisphosphonates. Parathyroid is probably the most effective. So the TBS score and BMD score both increases in parathyroid more compared to the other group. Now let's come to our case 1 again. So this patient has a high risk of fracture. What we did, because we all have to start treatment, so we started alendronic acid. So she developed gastric issues, so we shifted her to zolendronic acid. Now that's fine. So we have treated her. So what next? Next question is, how long do we have to treat her? So in that case, there are a lot of controversies about the duration of treatment, because only the bisphosphonates, denosumab, bisphosphonates, they have a stronger bone retention. Denosumab, abaloparatide, teriparatide, romosozumab, the bone retention is quite poor. So, but there's a lot of studies, they have found that if you use bisphosphonates like anti-resorptives and denosumab for a prolonged period of time, so if you use zolendronic for more than 3 years, alendronic for more than 5 years, denosumab more than 3 years, the chance of complications like osteonecrosis of jaw or atypical femoral fracture is on the higher side. So probably have to think of either cut short the treatment or think of a drug holiday. But having said that, you can only do that for patients with low risk of fractures. And if you think after having completed alendronic acid for 5 years, if someone is having, you have to re-stratify them again. And if this risk is very high, you have to continue, because if you stop treatment, they'll again land up in fracture. I have got few evidence I'll discuss for that. So how long to treat? Evidence what we have for alendronic acid is a FIT trial and FIT extension trial is a flex study. So they did alendronic for 5 years, and then after 5 years, it was randomized to have alendronic acid another 5 years, which is A10, and placebo. That means 10 years of alendronic acid versus 5 years of alendronic acid and 5 years of placebo. And they have found that in the A10 group, that means 10 years of alendronic acid, BMD continued to increase in spine, which is reassuring, but the hip density After 5 years, they kind of plateau. So not much further increase. But in A5, P5, that means when they stop alendronate for after 5 years and continue placebo, there is a decrease in spine and hip. But having said the fracture risk was not significantly elevated. So this is again an importance. This because of the bone retention is quite high. Similarly, for zoledronic acid, so 3 years versus 6 years, the Horizon pivotal study, what we looked as 3 years of zoledronic acid, and then after completing 3 years, the randomized receiving IV-Zol versus placebo. And you can see in the Z6 group, that means the patient who continued to have 6 years, their density of bone, spine, hips and spine continued to increase. The fracture risk reduction was significantly low compared in this 6 years of zoledronic acid, and the bone markers remained suppressed. This is all reassuring, and side effects profile was not too bad. So when you think of treating someone long-term treatment for osteoporosis, so customize the treatment plan as per risk factors, history of fragility fractures, BMD, obviously DEXA will help, and other diseases, what the patient is suffering from. And obviously, the very, very important appropriate risk assessment is very essential at every step. When you think of stopping or kind of trying different medications. Now, case 2, again, a 67-year-old lady with a known diabetic hypertensive PMR on long-term prednisolone, on methotrexate, no previous history of fracture or early menopause. Bloods are fine, means the creatinine was on the higher side, and the DEXA showing osteoporosis. So what will you do for this patient? So we know that this patient is at high risk, having osteoporosis, multiple diseases as well, but the problem is creatinine 2.5. So the eGFR was around 40 of this in this patient. So only drug which is recommended is denosumab, but you can use other drugs. Still the eGFR is around 30, but we decided to start denosumab on this patient because of various factors. So what are the evidence of denosumab we have? Now, Freedom trial has studied denosumab is nearly 8,000 patients, and they found denosumab is quite effective in both vertebral, hip, non-vertebral fracture reduction, and the bone density is significantly gained. Again, so we started on denosumab. So 3 years later, so the bone density, we repeated the DEXA scan, and that showed T-score is minus 2.8, which is definitely improved visually, and the femoral score is down. So one score has improved, one score has decreased. So what does it say? Does it mean we should stop denosumab? We should try different medications? Or we can try more different, like teriparatide, so which is more stronger. Now, only thing is, only crux is we should not compare T-scores when we are comparing the bone density. So always look for BMD when you compare. So probably look for what was the previous BMD, and that too from the same machine, because the least significant change varies if you do DEXA in a different machine. So in this patient, when we do a BMD, there is a significant increase. So 1.5% in spine and hip. So that means T-score, although showing slight decrease in the femoral hip, so BMD has increased. So there are probably some osteophytes and things which has made in the wrong result. So now what we do, that now we ensure the patient is on denosumab for 3 years and has a good response. So shall we continue denosumab? And if we, so how long to continue denosumab? So if we look at the Freedom trial with open label extension, so they did denosumab for nearly 10 years, and they have found denosumab is quite safe to use. Their efficacy in the spine, femoral neck has quite positive. The BMD gains has increased, and the fracture reduction is again lesser compared to placebo group. So we can use denosumab for this kind of patients. Only thing, when you think of stopping denosumab, the main concern is when you stop denosumab, the bone density suddenly goes down. And what happens, the fracture risk increases. So even if you think of stopping denosumab at some point, it is a 6-monthly injections. If you think of having stopping denosumab at some point, then you have to have some anti-resorptive sequential therapy. Don't stop denosumab straight away. That will cause decrease in bone density and increase of fractures. This is not appropriate for drug holiday. So we continued denosumab for a few years. Patient is still on denosumab now. So another case is a very challenging case. Is a young male patient with lupus nephritis, hypertensive diabetic, non-compliant with medication, had multiple hospital admissions, very poorly compliant with medications. This time admitted with SLE flare in ITU, had a pulse methyl-state, cyclo, stabilized, and when he was shifted to the ward, he mentioned some back pain, which confirmed L1 partial collapse. He self-discharged. On medication, obviously, what we decided, because he had lupus nephritis, again, we discussed and prescribed denosumab, which he never took. So, and DEXA, our hospital didn't have a DEXA at the time, so they requested as an outpatient DEXA. Now, a few months, almost a year down the line, he again admitted with the SLE flare. The back pain was stable, but CT showed multiple vertebral fractures this time. Denosumab would not commence earlier. We excluded CKD MBD because PTH was high, vitamin D was on the lower side, calcium was nearly normal. So vitamin D supplemented. He refused teriparatide, but again denosumab was discussed. Now again, he had few hospital admissions in between. In April 20, he had a right hip pain, had a right hip fracture. So he had a hip replacement as well, although he denied to start with. And you can see there's a significant worsening of the vertebral fractures, and multiple more vertebral has been involved. And while he was being shifted to the trolley, he developed sudden shoulder pain and chest pain, and he developed shoulder and rib fracture. So this is a gentleman who had middle-aged gentleman, long-term steroids with lupus, had multiple fractures. This is a very high-risk patient. So what shall we do for these patients? So here come the role of combination therapy or sequential therapy, especially in high-risk patients. So what data we have? So is a data switch study. They studied around 94 postmenopausal women. There are three groups of patients. So one, they have used combined therapy, so denosumab and teriparatide for 2 years, followed by denosumab. Another group, they received teriparatide for 2 years, followed by denosumab for 2 years. Another group, they have the denosumab to start with for 2 years, and then teriparatide to continue. Now, what we found that combination group, like when we use teriparatide and denosumab, their response was much better, probably slightly better, in both spine and hip BMD gain, and the fracture risk was slightly better. But although the fracture risk was not assessed in this study, they have given a narrative form, like they're given the fracture numbers. But interestingly, so basically when you use anabolic therapy followed by anti-resorptive therapy or in combination, their effect is better compared to when you use anti-resorptive start first, then anabolic. But interestingly, when you use denosumab first for 2 years and then shifted to kind of teriparatide, the hip density has significantly dropped over next 6 months. And although the spinal BMD has plateaued, and probably in these patients, the fracture risk may be higher, but that's not defined yet. But when you use anti-resorptive to start with, and then use anabolic agent like teriparatide, so their effect is masked as well. So the optimum effect of teriparatide is lost when you use denosumab to start with. So again, this is another study which has compared the potency of various drugs like raloxifene, oral bisphosphonates, IV bisphosphonates, denosumab, abaloparatide, teriparatide, romosumab. You can see over 2 years, right, the spinal BMD has increased, probably the best in a romosumab group, which is a new drug launched in India. Abaloparatide, we don't have it in India so far. And for hip BMD, I think the results are not too reassuring. Although romosumab probably having the strongest effect on hips, other drugs, even for teriparatide, the hip gain is not much. But the risk reduction is quite significant in the spine and not much in the hip fracture reduction. So again, you can see romosumab, anabolic agent has got more stronger effects or positive effects on bone compared to anti-resorptives. I'm just skipping this again. So it's the same thing. another important study when we are using teriparatide for high-risk patients. There's an interesting study which I found, because it's a cost-effective treatment. Many patients can afford teriparatide because they're around 3,000 to 4,000 rupees per month. So this study, what they found, they give two groups. One group received teriparatide for 2 years, and the second group received teriparatide every 3 months for 2 years. So 3-month teriparatide and 3 months gap in between. And another group, so one group of patients received alendronic throughout the time, and one patient alendronic naive, so never received alendronic. And the interesting finding is patients who received this cyclical therapy, that means teriparatide 3 months off and 3 months on alendronic acid, their effect was pretty much same or similar to the patient who received continuous kind of teriparatide. That means this could be a viable option for a long-term therapy for patients who can't afford teriparatide. So they'll continue alendronic acid, and then it can have 3 months teriparatide and 3 months off. So this is a kind of food for thought, really. So, so what are the strong combination strategies? So oral bisphosphonates plus teriparatide is definitely better compared to bisphosphonate followed by teriparatide. And another thing, IV bisphosphonates plus teriparatide is definitely better compared to either teriparatide or IV bisphosphonate. And denosumab plus teriparatide is definitely much more stronger than either denosumab or teriparatide. So these are the combinations what we use, especially for high-risk patients who are very high risk of fractures. Now, case 4. So again, elderly lady, alendronate for 3 years. So new risk fractures, which is a very common practice, common scenario. So patient taking medication, but again coming with either wrist fracture or hip fracture or spinal fracture. So what will you do? So the next issue is, firstly, check compliance. So even in UK and US, the compliance of bisphos is nearly 40 to 50%. So not many people are taking it. So how do you check that? Again, bone markers come in the picture. You can do that if you have a bone markers measured at the baseline. Now, evaluate secondary cause of bone loss. So like any other, like multiple myelomas or chronic steroid use, various drugs use. So if patient is non-compliant, that means patient hasn't taken drugs regularly, then ask them to take regularly, or you can try IV zoledronic acid or denosumab. And if patient is compliant, that means this drug is not working, so it is a treatment failure. That means patient on medication has a new fragility fracture. Then you can think other more stronger medication like either anabolic agents or denosumab. Again, you have to reassess the patient once they're on medication. So case 5, again, elderly lady, alendronic acid for 5 years, came in with a femoral fracture. But this is a atypical femoral fracture because of the location, and because the horizontal fracture line usually is quite vertical or oblique. So what is atypical femoral fracture? It's a first report in 2005 in patients receiving oral bisphosphonate. It's very, very rare. It's not very common, but you have to be careful. If someone on long-term bisphosphonate and they're coming with a hip pain, don't just ignore it. Just get an X-ray of the pelvis just to make sure there's no periosteal thickening, which could kind of warrant them having an early kind of stabilization. So after 2 years of exposure, the risk is quite low, is 1.8 in 100,000 population. But you can see after using for 8 to 10 years of bisphosphonate is nearly 113, which is not not insignificant. So nearly kind of 1 in 1,000, so which is quite high. So the risk is quite high at that point. So this kind of fractures occur with little or no trauma. And femoral fracture usually happens in the proximal 1/3 of shaft rather than in the neck, and usually bilateral. So if someone having atypical fracture, probably scan X-ray the other hip just to look for this periosteal thickening. And if you can identify, that has to be sorted as well. Another interesting concern is the osteonecrosis of jaw, which is defined by presence of exposure of necrotic bone in the maxillofacial region that does not heal within 8 weeks. So again, it was first detected in 2003, especially in patients involving getting IV bisphosphonates in metastatic cancer. Incidence is again quite low, 1 in 10,000 to 1 in 100,000. But having said that, if the exposure is quite high, after 8 to 10 years, is around 1 in 1,000. So which is not insignificant. So over 90% of cases, patient usually find in malignant disease, and most of the patients on IV bisphosphonates, we ask them to have a proper dental screening, which is again recommended by American Dental Association, and you probably have to stop or resort to other medications. Now, the very, very important thing is drug holiday. So when should you stop medication? And if you stop medication, when will you start treatment again? Because the patient will continue to lose bone density when you stop medication. So bisphosphonate has prolonged skeletal retention, and no other medications like denosumab, teriparatide, they have a bone retention rate. So when you stop denosumab, when you stop teriparatide, bone will again decay. And drug holiday is important, because if you give a drug holiday, that the osteoclast activity is again regenerated, and probably osteoblastic gets some rest, and chance of osteonecrosis and atypical is slightly reduced. And this has the kind of binding capacity for bone is highest in zoledronic acid, followed by alendronic acid, followed by resendronic acid. So these are the things that you can keep in mind. For denosumab, drug holiday is definitely absolute no. And thing is, if you think of it stopping denosumab, you have to resort to one more antiresorptive, either alendronic or IV zoledronic acid, for continuation of care. But drug holiday doesn't mean you stop treatment. It means you continue vitamin D kind of supplementation, calcium supplementation, regular bone marker assessment, regular DEX assessment. So that is also part of the treatment. So drug holiday doesn't mean you stop everything. But when you start medication, or when you think of restarting medication, is when the BMD is less than 2.5. So probably after treatment, the bone density had increased to more than minus 2.5. That is giving osteopenic range. But again, if it becomes more osteoporotic, then again, you have to start medication. If the BMD decreases greater than 3%, 3 to 4% on the monitored side, either spine or hips, incident of new fracture, or significant increase in bone markers. So what is usually happened is a PINP or CTX. If you have a baseline level, if you start treatment, either denosumab, they goes down by around 30%. So suppose patient is, when you re-stratify them or think of drug holiday, at that point, maybe DEXA is fine, bone markers is quite suppressed. So you keep on monitoring bone markers every 6 months. And if the the bone marker is coming back to the same level or going up, that's the time probably you have to restart your medication, or else the patient will land up in fracture again. So what are the bone markers? We commonly use P1NP and CTX across the world, really, and which is doable in Calcutta as well. So, but problem is for kidney patients, both P1NP and CTX is not relevant. So you have to do BSAP, which is the bone alkaline phosphatase. Sometimes TRAP is used, but it's difficult to get it in Calcutta. So what are the newer therapies? I'm nearly coming to an end. What are the newer therapies? So 2 new drugs are there. So romosozumab has been launched recently in India in May last year. There are quite a few drugs in the pipeline. Research is on. Odonacatib has shown promising results, but has been withdrawn because of high risk of stroke. So frame study, they have looked at romosozumab. So the patients, they studied romosozumab versus placebo for 12 months. And after completing 12 months, the patient received either denosumab or kind of placebo. And what they found is romosozumab is have a strong effective in both spine and hips. And the fracture risk reduction is significantly low. Again, in abaloparatide group, so the active study, they compared abaloparatide versus teriparatide and placebo, and they have found that abaloparatide is definitely more effective and more potent than teriparatide. And then what they did, they had an active extend trial. So patients who received placebo in active trial, they continued on alendronic acid, and patient who received this thing, and they received ALN. And they have found that 18 months of abaloparatide followed by 24 months of alendronic acid has a significant BMD gain, nearly 14%, in the lumbar spine and 6.4% in hips, and the fracture reduction in the this group around 84%, which is significantly significant. Now, there's a few take-home messages. So early detection diagnosis is very essential. We need to have a multidisciplinary team approach like orthopedics, geriatrician, endocrine team, physiotherapists, orthotics to have a proper package care. Judicious use of fracture risk assessment is also very important, especially whom you can't define with DEXA scan. Drug duration holiday, drug holiday is basically a matter of debate. But again, if you think you have to risk stratify patients at every steps and then think of the next step. Newer diagnostic strategies to quantify the bone quality is very, very important. There are a few new drugs in the market which has shown very promising results. Thank you very much.
Thank you, Parthajit, for quite comprehensive and excellent talk on the subject regarding the clinical approach. I think there will be a lot of questions. I want to ask you one or two small questions. One is
Yes,
regarding treatment, as it is a silent disease, not diagnosed before a fracture. What do you suggest for very early detection of osteoporosis, except this FACT score? Is there any low-cost emerging technologies that can help in the early diagnosis?
So is it absolutely right question? I think basically we have to start detecting patients early. So for us, for like all rheumatoid patients, we detect them quite early on. There are several camps like pharmacy companies, they go around the various doctors to do a forearm DEXA, which is probably low cost, but not very sensitive. So many patients are getting wrongly diagnosed with osteoporosis. So ideally, only way to get the diagnosis right at this point in time to do a DEXA properly, I mean DEXA scan of spine and hips, which costs around 3,500 to 4,000, which is not very expensive drug. And if you kind of counsel patients, they are more than happy most of the times. But thing is, patient who are having either someone is more than 65 for women or more than 70 for men, if they have any fractures early in the past history of fracture, past history of vertebral hip fracture, they have any fracture themselves or family history of fractures, or any secondary osteoporosis. So those are the patients at high risk of having fractures. So risk stratify them. Probably if someone is 70 and having a fracture, no need for a DEXA scan. So we have to start treatment anyway. So basically, we have to risk stratify the patient and identify someone is having osteoporosis and then start treatment.
Cancellous bone assessment cannot be done with this
So with
computerized method.
So with DEXA, probably we can't do it, but
Cannot.
TBS scores are having most of the centers. I think we are having in our centers, we are trying to get it. With TBS scores, you can assess the bone quality, all the trabecular networking. And with TBS score, if it's positive, then probably we have to start treatment.
Another thing is the fallacies of the T-score. Having same T-score, different patient population have different fracture risk. I think that also gives importance to the physicians that not T-score is not that important. It depends upon the patient population receiving corticosteroid, diabetes patient, elderly age group, I think so. So if you say one or two lines on that, so this is a commonly done DEXA interpretation is done. So who are the subjects? They may behave differently even with the same T-score.
That's absolutely right, sir. T-score is a value. It is this -2 standard deviation. So ideally, we should look at the BMD of the spine. So rather than just a T-score, even for T-score, we can't compare the T-score for different patients. Like if patient is having a BMD earlier on a different machine, so we can't compare T-scores at different point scale in a different machine. And because it's just a 2 standard deviation from the BMD, so that's just a figure. So T-score is not a value to be taken into consideration for absolute diagnosis of kind of osteoporosis. So that's just a figure which is derived from the BMD figures. And because we're a -2 standard deviation, we give us a T-score. But WHO and ISCD, they have defined everything through T-score. That's because that's the only best possible score what we have. But that's not the gold standard for either diagnosing or defining a long-term treatment plan.
For Indian population, any Indian score that can be validated with FRAX?
So we have FRAX
Low
scores,
cost.
and what they're looking a lot of studies now. What they think, rather than, because 20% major osteoporotic risk factors is valid for US population.
Yes.
But Indian is around 15%, and
Yes.
3% of hip fracture is around for US population. So whether it is coming down to 2.5, that remains a matter of debate. So what they think for Indian fracs is probably 15% and 2.5%. That's what they have quoted roughly. But again, that's needs to more studies are required.
So I think other panelists may ask some question, and there is also some question put in the question answer. So first one is, I can take, or you can take, Parthajit, from the Q&A.
Okay, sir.
First one is Dr. Shivendu Ghosh, andropause and osteoporosis. A long question.
So
all are from Shivendu Ghosh. Andropause, osteoporosis, obese woman, less than. So first 5 question.
Right. I said,
To take the short, make it short if you can do, because these are all very long questions.
So andropause is basically a presentation by itself, but I think not just andropause, men are at higher risk of having osteoporosis, which is being identified regularly. But any men around more than 55 or 60 need to be assessed properly, and we have to look for any secondary osteoporosis, like any testosterone deficiencies or other risk factors like malabsorptions. So if we exclude cause of secondary osteoporosis, and if we define osteoporosis and detect them early, we have to start treatment in simple ways. Because equally, it's not that men won't have osteoporosis. Men are equally at risk. And the fracture, once they have the post peri-fracture mortality is very high, and the complication rate is very high, especially in men as well.
The next one, I think, obese woman less vulnerable. Why?
So this is probably not true, but things, because in obese women the estrogen level is high, so there are some thoughts that because estrogen level is high, the bone density remains strong. But again, there's a lot of matter that remains a matter of debate, because few people think that because they're obese, they put more pressure on the bones. As per Wolff's law, the bone strength would be higher. So that gets usually negated. But again, the risk stratification and identification remains the same, like regular bone density scan for high-risk patients. And if they're found osteoporosis, that has to be treated. But they're not immune to have osteoporosis.
Whether in calcium supplements from foods or drugs.
So
usually from foods, I think.
I think definitely preferred, because the total calcium is either 1,000 milligrams or 1,200 milligrams. Problem is young patients. So if someone is not calcium deficient or vitamin D deficient, and if you give calcium for a long time, so that will cause kidney stones and other complications. There are some studies have shown some cardiovascular risk as well, but some studies have negated that. But only thing is, if you supplement calcium, has to be taken with food, because the oxalate in the urine gets chelated, so oxalate in gut and calcium gets chelated. So the oxalate is excreted through stool, but if not taken with food, the oxalate gets absorbed, and the chance of getting urinary stone is much higher in those patients. So unless required unnecessary calcium supplementation, I wouldn't recommend. So if it's a young patient, so probably do vitamin D supplementation. That will look after the blood, this level, calcium. But even if you give calcium, it has to be given with food.
Minimum dose of oral steroid doesn't cause osteoporosis.
So again, it's a matter of debate. So ideally, if it's more than 7.5 milligrams, more than 3 months, that's a risk factor. Several studies have even inhaler steroids can cause osteoporosis as well. So low dose steroid long term is definitely a strong risk factor of osteoporosis, like steroid induced osteoporosis.
I cannot see any. If you can see, yeah.
So
Parthajit.
that is zinc and osteoporosis. So the medical companies are selling that using zinc will increase the bone strength or giving magnesium added on to the bone strength. But supplementing zinc and magnesium, there is no strong head-to-head trials because these are all difficult to assess. But overall, this what stands true at this point is calcium and vitamin D supplementation is the gold standard. So you supplement vitamin D optimally before you start medication, especially in patients who are having fractures, high-risk patients.
Any role of you didn't mention anything about calcitonin, not of much use these days. Inhaler calcitonin.
So role is poor, but I think as an adjuvant therapy, so when you're already giving alendronic acid or teriparatide or denosumab, if patient is having high risk of fractures, you can use it as an adjuvant therapy, or you can't use any of these medications like either bisphosphonates or denosumab, either because of price or complications, especially in kidney failure patients, then calcitonin has some role. But his efficacy is very, very poor. So SERMs like base-doxyphene, raloxifene, or calcitonin, the efficacy in the spine and hip is very, very minimal. So 1 to 2% chance of BMD rise.
There is one thing more, Partho.
Yeah. Yes.
Calcitonin may be helpful as an anti-inflammatory for pain relief in the first month.
Pain-wise, it does definitely
Skeletal
helps, yes.
pain,
But
right.
particularly in spinal compression,
Spinal pain.
waist collapse. That is
Absolutely.
quite helpful.
That helps. I think that's the reason the orthopedics use it routinely, just to minimize the pain.
I don't know if there is any question. So if there is no further question, I over to the other panelist and Dr. Amal Kumar Banerjee, our ICP chairman.
Partho, one more question, not Parthajit,
Yes.
not Partho.
That's
In your second case, I think second or third case, you went for denosumab. The creatinine was 1.3 or 4, I
2.3,
think.
I think.
2.3.
2.3.
Yes. Teriparatide, couldn't you have used it
Sir,
the first?
Yes, so we discuss teriparatide because you can use teriparatide up to eGFR of 30. Patient's eGFR was around 40 range. So we discussed teriparatide because patient was non-compliant and the price. Then we thought probably if we one shot of denosumab, the patient is kind of sorted for next 6 months. So that was a clinical decision
Compliance
rather
issue.
than
And that poor patient of male SLE
yes, sir.
who didn't take either of denosumab or teriparatide in spite of your counseling.
So that was a challenge.
He had to opt for bilateral hip replacement. That was more costly, I think.
And sir, because it was so kind of fragile, because when she was getting transferred from post-operative after the surgery, when she was getting shifted from trolley to bed, he developed 2 fractures, shoulders and rib. So these patients are really, even despite whatever treatment you give, either combination therapy, how much bone gain you will achieve is a matter of debate.
And one more thing is very important in our patient. We should discourage patients from taking PPI. And that is also a cause of secondary osteoporosis.
Prolonged PPI, yes, sir, absolutely. Because problem is they are on steroids, they are on PPIs, they are anti-epileptics, there are multiple drugs, all can cause low bone density.
Partho's lecture was excellent. Yeah, really, we learned a lot from it.
But can I have a comment?
So Sarkar, there are a few more questions from Shivendu Ghosh. I'm just reading those questions.
Yes, sir.
He has
To
got the
continue.
unending list of questions. First is any relationship between osteonecrosis of hip and osteoporosis?
I think we discussed, slightly regarding side effect of.
The pathophysiology of both is completely different. So I think osteoporosis is more of a vascular phenomena and osteoporosis is more of a bone mineral content.
Metabolic.
Yes, more of a metabolic. So the pathophysiology is completely different, but I think they can be, one bone is fragile, many patients do have osteonecrosis as well. Especially when they're on steroids, or they have SLE, there are other various diseases, Apla syndrome, so those kind of patients.
Even in diabetic also there is
Yes,
sometimes
any
osteonecrosis.
high risk patients.
There are two questions. You have discussed those things. Just like after what age one should go for DEXA scan, and second is injection decadurabolin in CKD for osteoporosis. I think you have discussed these issues.
Yes, I've already discussed. So. But decadurabolin, I think there is no recommendations or any strong evidence. So anabolic steroids is most of the times is discouraged.
Moreover, it causes water retention also. And this,
There's different other problems, heart failure and things.
Okay.
Parthajit,
Yes, sir.
so you have done a very good job, because I thought that you have done justice to the subject. Because actually, while I was searching for the subject, as I was given the responsibility by Dr. Banerjee, so I thought that you will be the right person, and two Partho will be put in this program. So it is an excellent program. I want to learn, just want to know from you. It may not be directly related to osteoporosis itself, but then a lot of patients come to us with rheumatoid arthritis. And you know that with some of the prescriptions, we find that they are using also the interleukin-6 inhibitor, that is your tocilizumab.
Yes, sir.
Tocilizumab they are getting. What is the role of tocilizumab on the BMD? Is there any relation, or there is no proof of tocilizumab increases the BMD? Is there any controversy?
So problem is we can answer in two ways. One is there is no direct role of IL-6 blockers on BMD, but problem is when the disease remains very, very active for a prolonged period of time, they have active synovitis, that causes a low bone density by itself. But when you control the disease and the inflammation burden or the synovitis is low, that the cytokine levels in the blood goes down, that may have a kind of a positive effect on the bone density itself, rather than the direct effect of tocilizumab on bone.
Again, there is one question from one PGT possibly. Only vitamin D supplements without calcium supplement can cause any harm to bone health?
I think it's a good question, but I think it is two different facets. One is the young patient, one an elderly patient. If it's a young patient, if you do vitamin D supplementation, that will call calcium absorption from the gut. So the calcium levels are well looked after only with vitamin D supplementations. But whereas if you are treating someone with osteoporosis in an elderly population, that means if you're kind of building a house, chun, surki, probably calcium, vitamin, both are required. If we supplement one and someone is deficient with the other, so that there will be bone formation, but the bone won't be of good quality. So when you are supplementing someone or giving bisphosphonate or teriparatide, you should make sure that the vitamin D and calcium is well supplemented before you start. Or else they'll have bone formation, but the quality of bone won't be good.
Again, another question for Shivendu Ghosh. Possibly this is the last one. Osteoporosis in thalassemia.
Good question.
So again, is a chronic disease, and I have to have a look whether that has got a direct role. But hemophilic patients who have hemarthrosis, they sometimes can have joint inflammation, swelling, hemarthrosis, and they can have significant osteopenia, limited osteopenia or osteoporosis around the joints. But as a chronic disease, because there's multiple nutritional factors with thalassemia associated, whether they are causing it or the disease by itself, I have to look, because I'm always scared when Shivendu sir asks questions.
Now, what about this extra? I mean, the thing happens in thalassemia, that is extramedullary
Aplasia.
I think because medullary expansion is there, so there's always a possibility that there will be
possible spinal fracture.
Spinal hips.
Even those questions are very tricky and very
I'm always scared.
thought-provoking. Thought-provoking.
Okay, thanks to both Partho and Parthajit. Now I request Dr. Rothin Sarkar to give vote of thanks to one of our course directors. Rothin, please.
Yes. Thank you, Amolda. Excellent lecture by
you,
Parthajit. As usual, Parthajit is now actually it has become icon of osteoporosis research in India.
Not
We
at
had
all.
a lot of workshop. So I must thank him for his excellent lecture. Now I must also thank Partho, our old friend, for conducting the proceedings. And I must also thank our other directors, Minal Roy and Sibendu, for their participations and the PGTs. And I also thank our office staff and the micro lab. Now over to Amolda for conclusion.
Thank you, Rotin. Now we're going to adjourn this session. Our next master class will be on 14th of July. On that day, we'll discuss case-based approach to hypercalcemia on 14th of July, Sunday at 11:30 a.m.
11:30.